Thank you, Rose. It's really such a privilege for me to be here, and I really wanted to just thank Rose and thank folks for inviting me. I mean, it's really being a chair is actually quite boring and or tedious. The coefficient of friction is very high, and just listening to people talk about integrating mental health services in general medical settings, it gets me, it allows me to feel like maybe there's hope for me after I get done with this chair stuff, that you actually can do something productive with my life again. But this is an area that is near and dear to my heart, and I know to all of you. I'm just going to try and blow through the early part of the talk. Is going to be a little bit conceptual, but then I want to get into and talk about some of the things that we have done that maybe would just, it's not like anyone has, as I said to someone a short time ago, it's not like any of us have cracked the code on how do you integrate things, right? So the idea that, oh, anybody is going to get up and say, I'm an expert in how to do this, it's like, wow, I'm going to be in the front row because I don't know that we've cracked the code. Most of this work has been done in research settings, and the thing that, one of the questions that I really want to pose to the group is, for all we talk about integration, why has it been so hard for us to do it? So I mean, I showed some of my disclosures. So really what I'd like to talk about today is talk a little bit about the relevance of behavioral health and substance use disorders to the public health. But I think this is that's kind of preaching to the choir. I want to talk a little bit about that issue. How is it that this has been so hard and continues to be so hard? And then how might we integrate services and find a way to improve access to care and to, by doing that, help achieve what people talk about as a triple aim: better patient experience, better outcomes, and reduce healthcare costs. And then one of the things I'll do is talk about one model that has been championed around integration, and you've heard a bit about this, is the chronic care model of illness management. So one of the things that I think we struggle with here is how we think about things. And I always liked this quote from Charcot, because it's very easy to get stuck in a particular frame of mind when we think about physical health and mental health. And this is true not for the great unwashed necessarily. It's true for me, it's true for all of us. And I've been working this. I mean, I trained as a pediatrician, I'm trained in psychiatry. It should be the air that I breathe, and every once in a while I have these thoughts like, well, gee, this is really weird. Why isn't the emergency department configured with special areas for the mentally ill? As if, I'd never thought about it before, because emergency rooms are just one way, and mentally ill people are just annoyances that show up and get in the way of real medicine. So how we think about things really does matter, and I think there are structural things we can do, but our attitudes are part of the issue. How do we get there? Well, if you think about it, and this is relevant to some of the stuff that Rose and I had the privilege of working together on around functional somatic symptoms or medically unexplained symptoms, is, we think about illness and disease in a very specific way in Western medicine. So when we think about illness, or at least when I'm talking about illness, what I mean is the subjective distress of our patients and the behaviors that go along with that. What is it like to be sick, to be ill? When we talk about disease, we're also talking about something very specific. And those of us trained in Western medicine, we're thinking about a process that's characterized by objective evidence. In the old days, we think in terms of pathology that, quote unquote, explains the patient's symptoms. some of the great achievements of Western medicine have been driven by the biomedical model of disease. What does the biomedical model essentially say? It says disease causes illness. If you have illness, there's a disease that's causing it, and that explains the suffering of the patient. And when you think about health, pretty simple, right? It's dichotomous. You're either well or you're sick. There's some other implications culturally about this whole notion. And so when you think about illness that's caused by disease, fine, you have diabetes. Well, that's a legitimate illness. You obviously didn't want to bring it on yourself. It's not voluntary. And how can you be held responsible for having diabetes or asthma or something like that? The flip side is, if you have illness and there isn't explanatory disease or disease that we have properly conceptualized, I think that the unspoken perception is that somehow it's not exactly cricket. It's illegitimate. Must be something this patient is doing or saying. And really it has less to do with medical care than it does with the patient having some sort of socio-moral problem. It has more to do with sin than disease. Now, the reality is, though, now and 100 years plus ago, reality challenges the biomedical model, right? So many of you who are working in primary care settings, number one, disease isn't always associated with illness, but more importantly, illness is not associated with clear-cut evidence of disease in the traditional sense. You see a lot of patients with functional or medically unexplained symptoms. But when you think about it, most mental disorders, we talk about anxiety disorders, depressive disorders, bipolar disorder, and we codify them as quote unquote real, and they are real, but in the specific way that we've talked about disease, it's hard to characterize them as diseases in the traditional sense. The whole term neurosis was invented to be applied to a group of patients who presented with nervous symptoms, but when they died and you cut up their brains and the rest of them, you didn't find disease. So that was where the term neurosis came from. So in a sense, what our discipline in the mental health disciplines, we've been sitting on top of a whole category of quote unquote functional disorders for the most part. Now, what's evolved over time is that there have been these parallel, and I'll use the word, it's charged word, but it's really segregated systems of care. There's a mental health system of care that evolved right alongside traditional health care, where the whole idea, it mirrors the whole idea of pathology explaining illness, right? So what happened, a couple of smart guys like Freud and Janet said, well, you know what? There could be psychological causation of these symptoms, and we're going to try and explain that. And we talked about things like psychopathology. Alongside this system of care, though, is, the confidentiality standards weren't quite the same. We even struggle with that now. And I think that reflects the fact that we think differently about these problems. It reflects stigma. There are whole separate systems for billing, for reimbursement, everything else. So we have these parallel systems of care. That integration is an effort, how do we bring it together? Because what we have now, we have traditional health care where the focus is physical health and disease. The bottom line is a lot of physical symptoms are functional. We have behavioral health care where the focus is on mental health and illness, absent disease, but plenty of mental symptoms are actually explained by disease. That happens too. And so psychiatry, in a lot of ways, we've had one foot on each side of this, and it's the medical especially supposedly focused on problems and disorders of thinking, emotion, and behavior, and ought to be relevant to both systems of care, and hopefully have something to say about how you begin to think about integrating it. I think all of you know that mental health and substance use problems are really prevalent and impactful. About 20% of the population at any one time suffers from a mental disorder. Maybe 4 to 5% of the population has a serious mental illness. These disorders are more prevalent in people who are physically ill, especially those with chronic illnesses, more prevalent in the underserved, in low income and vulnerable populations, and they typically begin early in life. Getting back to, I mean, the pediatricians and the child psychiatrists, we can't help ourselves by coming back to kids. And if you look at most of the serious mental illnesses, they typically begin early in life, at least half of them by age 14, 3/4 by age 24. What's interesting is, though, is the earlier you present, the longer it takes to recognize that that the mental disorder is present, which is kind of a convoluted way of saying we do a lot better recognizing mental illness in adults than we do in kids. We do it faster anyway. So we know that physical disease can impact mental illness and addictions. We know that mental illness and addictions can serve as cause or a risk factor for physical disease and injury. And we know that if you're an individual who has a physical health condition, that having a behavioral health disorder or a substance abuse disorder can have a very negative impact on the course of that illness. We know that those patients, compared to their peers without behavioral health conditions, same disease, have higher levels of disability and mortality. They are vulnerable to have worse course because they may be non-adherent. They may have issues with their diet. The disorder may affect their behavior in caring for the condition, but it may also influence the pathophysiology of the disease itself. We know now that depression, anxiety are associated with higher levels of inflammatory markers, and we see this again and again in the relationship between, say, depression and cardiovascular disease. Now, these disorders impact the public health in all sorts of ways. But really, and again, I say this because we all know it, but we tend not to think about it. When you think about the impact of these disorders and the way that our healthcare system is structured, you look at the young people that are coming in and out of your office. What are the 3 leading causes of death? Number 1, accidents. Number 2, depending on the age group, suicide. And number 3, violence. And all of those things highly impacted by behavioral health conditions and substance use, and yet we tend not to elevate our concerns about these aspects nearly enough. We haven't integrated care for those conditions in not just primary care settings, in our own emergency rooms, in our own hospitals. So, these conditions can be associated with increased use of services, increased costs. If you look at people who have a behavioral health condition with a chronic medical condition, medical costs are 2.5 to 3 times as high. They tend to have longer lengths of hospital stay. They're more likely to be readmitted after hospitalization. And there are all sorts of other societal costs. So that's my sermon for today. But, so we know that there is some good news, though. We increasingly now, and those of us who've been fortunate enough to train in psychiatry the last several decades, there are evidence-based treatments available for a variety of mental health conditions and addictions. Are we where we want to be? Not necessarily, but we're way ahead of where we were 30, 40 years ago. So that's the good news. The bad news that everybody in this audience knows is that most people who have behavioral health needs don't get any services. They get nothing. And the ones who are most vulnerable to get no services are low-income people, minorities, rural folks. I don't know if any of you work in rural settings. Rural settings are particularly significant. And if you actually look at suicide rates, even though more people who kill themselves come from urban settings just because more people live there, suicide rates in both kids, we just wrote a paper on this, in kids and in adults, twice as high from rural settings. And it's not just because of firearms. It's more than just firearms. Of the folks who do get services, many of them get inadequate services. So maybe only about 20% or less of those who actually present services get services meeting evidence-based standards. And again, this tells you we're seeing the tip of the iceberg. Most people at risk for suicide are unrecognized and or receive no treatment. Yet we know that access to care is actually the better the access to care, both for general medical services and mental health services, the lower rate correlates with lower suicide rates. So what's the problem? Well, this whole issue of segregated systems of care, it carries over because there's a mismatch between where the patients are and where the behavioral health professionals are. So if you really look and you try and quantify the number of behavioral health presentations, probably about 80% of behavioral health presentations take place in the general medical sector, okay? That probably isn't that surprising, right? Except there's one really kind of funny problem, which is that only 5% of behavioral health specialists work in the general medical setting. 95% of us work in specialty behavioral health settings. You look at ED visits, 5 to 10% of emergency department visits are primarily for a behavioral health condition or an addiction-related problem. And if you look at general hospital admissions and in outpatients, somewhere between 25% and 30% of those patients are coming in with a comorbid condition that may or may not be recognized. So we talked about this again. So even though 20% of the behavioral health presentations are in specialty settings, 95% of us work there, and we still we still don't have enough capacity to take care of what's coming our way. The other important point is if you look at patients with serious mental illnesses, their lifespan is considerably shortened. On average, you look at it's at least 10 years, and that may not sound like a lot. Smoking, if you're a regular smoker, that decreases your lifespan on average by 7 years. So if you have, now again, that's probably part of the problem here with serious mental illness, but half of these patients have chronic medical conditions, some of them not unrelated to the treatment that they get. And that just gives you an idea of what it looks like about this whole patient-provider mismatch. And this is one of the issues that integration challenges us to try and overcome, because we know that this mismatch is associated with adverse health outcomes. That our patients with behavioral health problems, you know it yourself, they don't do as well, they're harder to treat, and they're more costly. The costs of these patients are over twice as much as those unaffected by behavioral health problems. So again, here's a picture of the triple aim. And certainly it's going to be harder to achieve the triple aim when the conditions that we're talking about are really considered outside the purview of traditional healthcare. And I think it's a premise worth further testing, that if we really integrate these services, we may increase the likelihood of achieving the triple aim, and I think a lot of us are betting on that. Now, the first question, most of you, do most of you work in suburban, urban settings? Any of you, how many rural settings? Most urban or suburban, okay. So if I'm a primary care doc, my first thought is, okay, well, you know what, I'm gonna identify and refer, right? I mean, it's a very reasonable thing to do. It's what we do with other specialties. The problem is, what I'll tell you, and I think you probably know already, is that specialty mental health referral isn't everything it's cracked up to be. First off, a lot of folks are never identified and aren't referred. But even when you look at those that are referred, we thought we were pretty good at linking folks with specialty mental health care. We went back in our own work and we looked at in a variety of different settings. where we did facilitated referral, not just like, oh yeah, go see somebody. Oh, what's your insurance? Here are the names of some people. Can we help you? 6 months later, who wants to guess what percentage of patients had even one mental health visit 6 months later? Yes? 1 out of 3, okay? That was pretty horrific. We repeated it in some research-based studies where we really tried to get really good at it. And the first crack, we got it up to about 40%. And then we got it up around a little over 50%. The best we ever did was a study where we screened for suicidality in adolescents, and we managed to get, now these were adolescents who screened positive for suicide in primary care and were considered at risk by their pediatrician and by the social worker who worked in the practice. 60% of them had a mental health visit several months later. Hard to celebrate, you know. So what are some of the issues, right? Well, there are barriers. People can think about different barriers to care. We can talk about structural barriers to care, and we can talk about attitudinal barriers to care. We all know the structural ones. Certainly in the US, we worry about this more: lack of financial means, insurance restrictions, geography, rural, urban, can you get to your doctor? Transportation, the ability to get there. Shortages of providers, this is universal. The provider experience and training, and all sorts of inefficiencies along the way. What's probably even more of a barrier when it comes to individual patients reflects attitude. A lot of patients have low perceived need. They may want to manage the condition on their own. They may be really pessimistic about the effectiveness of the treatment that we have to offer. They lack trust in treatments or providers, and they especially lack trust in those of us who are specialists, who are not as familiar as you are in the primary care setting. So there's a tremendous amount of stigma. And moving all of those attitudinal things aside, the other thing that makes it difficult, particularly around referral, is Newton's first law, which is inertia. It's very, I mean, I have trouble getting my teeth cleaned and, doing that on a regular basis, never mind, juggling some of the complexities of dealing with a chronic medical illness and a comorbid specialty mental health problem, right? So primary care, everybody thinks it's the answer, right? Well, I think it's very important, and I think it certainly can be, and I was really drawn to it in large measure for what the meta-communication is of doing behavioral health in primary care medical settings. Because when we talk about primary care, it's first contact healthcare, comprehensive, delivered longitudinally within a community-based medical setting. We all hear and talk about the medical home. Again, the goal is to provide something that's accessible, continuous, comprehensive, family-centered, coordinated by a personal physician, committed to evidence-based practice, where that medical home provides or arranges care with other qualified professionals to meet all of the patient's health care needs, including prevention, acute illness management, and very importantly, chronic illness management. It's a great idea. It's an even neater trick to actually deliver it. Why is it a good idea? I mean, well, I think conceptually, it challenges stigma, right? I think if your primary care doctor cares about your emotional health, cares about whether you drink too much, I think it emphasizes that health can't be parsed into physical health and mental health, that it's a unitary construct. And it really gives those of us who do behavioral health some added credibility and enhances the importance of what we do. Plus, people don't trust behavioral health specialists. You're much more familiar to them, and they see you as resources. The other thing it challenges is that many of us, and this was true for me when I was in pediatrics, I remember I would just literally, be getting through the visit and just be said, please don't say he's pooping his pants. Please don't say he has stomach aches. Please don't tell me that he's having trouble paying attention in school, because it was going to open a whole can of worms, and I was so close to just being able to move out of the room. It's very hard. And the less you feel comfortable with it, the more you're going to be inclined to avoid it. It also becomes an opportunity to strike while the iron is hot. The more steps in the process, the more likely you get a decrement. It also helps with geography. If you're in a rural setting, if you can provide everything in one setting, even if it's not perfect, perfect is the enemy of good enough sometimes. The other thing that is so appealing about it is that it leverages the infrastructure of general medicine. There's just no way we're going to be able to deal with the shortage of behavioral health professionals by just growing more. I mean, I think we need to do that, but that's not going to be adequate. I mean, certainly we need more specialty behavioral health providers. What I'll charge this group, and that I think is, I think one of the keys to cracking the code is, well, we talk later on about the whole idea of care managers. The issue is, how do you create kind of a next generation, thank you, of behavioral health professionals that can really bridge the gap, right? So we talk about quantitative strategies, let's just get more providers. But really, this is where we're at. We also need to think qualitatively. How do we increase the impact of the specialists that we have? How do we increase the impact of our general medical providers? And I think one of the things that's so exciting about what I'm hearing from David and Sanjay is that, how do we apply technologies to improve care? So the chronic care model of illness management was something that was really developed by an internist, Ed Wagner, out at the University of Washington. And it was really originally developed to deal with things like diabetes in general medical settings. And what the premise was there is that, the best care is going to be achieved when you create a group of informed and motivated patients and families, and you put them together with a team, an interdisciplinary team of professionals who actually talk to one another and who take responsibility along with these patients. They partner with them to manage their care over time. What are the goals? You want a mutually understood and agreed upon care plan with the patient and family. You want to make sure that the patient and family has the skills and confidence to manage the condition, and you want to make sure they have access to the appropriate treatments and to continuous follow-up. Here are just some of the things you heard a little bit earlier about some of the core elements. To really pull this off, and this group has a tremendous opportunity. This MPA can be something truly fabulous, but the caution I'll put, it's also something that would be very easy to squander. I'm going to really challenge folks. The real challenge here is not what you do now, it's what you put together that turns out to be sustainable, that you're still doing 10 years from now. Because we all do great when we have a grant, and then the grant goes away and the improvements go away. And that's the challenge. How do you have something that's sustainable when you're done? How do you have products that you can feel good about and be proud of when you're done? These are the different elements of the chronic care model. You need an organizational team. The primary care docs need to have some decision support. They have to have access to the right sort of information, but also access to the to mental health professionals who can, to specialists. But you've got to change the delivery system. And the core element in changing the delivery system is really finding a way to incorporate a care manager. If you boil down all of the studies, when you look at the studies of collaborative care interventions for depression and anxiety, one of the critical elements always is this whole issue of care coordination and with a care manager. I'm going to pass over some of the other things that people say you need you need not just decision support for the docs, but also decision support for patients and families, and you want to leverage what's in the community. So what do we do with collaborative care? With collaborative care, we integrate behavioral health professionals within the general medical setting in a variety of ways. Can integrate them as an educator, as a consultant, as a clinician, as all of the above, some of the above. You want to shift the focus to a longitudinal perspective because these disorders are generally chronic disorders. And again, it relies on teams, but the glue is around the care manager. The other important element is that we have to think about this as part of a larger system. We have to think about this as part of a stepped care model. What does stepped care say? It's basically that we offer different levels of care depending on the disorder type, the severity, the complexity, and its persistence in the face of intervention. So, that's really, if you just draw it out, primary care is where most of the stuff happens, and this isn't even to scale because this is much less where things happen. This is where more of it happens. So I'm going to talk a little bit about a couple of practical efforts that folks have done in the United States anyway, to try and integrate mental health services in primary care settings. Some of them have directly applied the chronic care model, but I'm going to talk at first about a couple of projects. The Massachusetts Child Psychiatry Access Project. This was established back in 2004. It was a statewide initiative. The legislator have given them a little over $3 million a year. Comes out to about $2.20 per child. They divided Massachusetts up into 6 regions. Each region has a little consultation hub. That hub has a child and adolescent psychiatrist, a therapist, and a care coordinator. Their goal is to be available to primary care docs to help them in the diagnosis and treatment of pediatric behavioral health problems. They have a telephone hotline that serves as the entry point. It's available during regular business hours. The aspiration is that they respond within 30 minutes. About 90% of the time that happens. And the primary care practices are supposed to enroll. The main thing they do is this prompt telephone consultation with a child and adolescent psychiatrist. For selected cases, they may be able to pull together an expedited face-to-face consultation, but it's a purely consultation model. They aren't going to pick up the case. They're going to send it back to primary care. If you need to refer to a specialty setting, they will help you with that. And the thing that they do also is focus on continuing professional education for primary care physicians and clinicians. And it's a combination of case-based education, which you can get right over the telephone, formal CME presentations. They have a website with materials. We have a website also for those of you interested in some issues around kids. Ohio Minds Matter is free, and it has some pretty useful information on there about how to improve the care of kids with mental disorders. They have a newsletter, they actually go to the practices. Anyway, I'm gonna pass over this, but again, this program has had some success. Most of the questions relate to diagnosis and resource management. Next in line, people would ask questions about how to use medication, but most of the encounters didn't result in more medication being prescribed. So that's been a model. The other model in Washington State is the Partnership Access Line. A little different, tailored to a different state with a different geography. It's a centralized team of child psychiatrists. They have some reliance on video consultation. They do some regional provider conferences. And there's some nice things about it. They do a consultation by phone. You can call in on a toll-free number. After the visit, what this group will do is they will fax the primary care doc a summary of the interaction. They have a social worker to help with referral assistance. They'll send them parent handouts and tip sheets for patients and families. They actually have their own care guide that's available to the primary care docs. And for selected cases, they'll do a telepsychiatric consultation. And primary care docs like it a lot, just like they really liked the Massachusetts program as well. Now, I know I'm talking progressively faster because I really don't have too much more time, but this is, I think, a real-world example of applying the chronic care model without grant support. We found a way to pull this off. And we did this in a large rural pediatric practice in Western Pennsylvania. This model has since been disseminated across a whole network of practices operated by the Children's Hospital of Pittsburgh. But it started out as we were just flying by the seat of our pants, trying to take care of kids in this large practice where they had a high percentage of Medicaid cases. They had limited access to mental health services, limited access to psychiatry, and the community mental health system was overwhelmed. What really was a boon for this community is they had a committed group of very well-trained, very passionate primary care pediatricians who weren't willing to look the other way. And so we put together a group. I started going out to this practice as a consultant, but it was clear that the hospital wasn't going to let me continue to do that because we were losing money hand over fist in a straight psychiatrist spending all day doing consults there. So we had to figure out a way to finance the model. What we did, once we came up with some iteration about how to do that, is we really were able to lay out a model of care that was really very much based on what people have written about in collaborative care. And we built it around a team. Our team, and there isn't just one way to do this, this team was made up of the primary care doctors, a care manager who happens to be a nurse in this instance, and then we added a social worker. And that care manager was the key transitional element in this model. They were the primary liaison between primary care and specialty mental health. And their responsibility, they did things like the initial patient and family education, ongoing case management and treatment support, and then the child and adolescent psychiatrist, that was me. Now, what was the role of the primary care doc here? And what I can tell you is not everybody in this practice was crazy about the idea because they thought this was just going to add work. But there were a couple of early adopters, and I can tell you, once people saw how this worked, people actually did get on the bandwagon. What was the expectation for them? Their job was to identify psychosocial problems when they saw it, to case find, do their best to establish an initial diagnosis, but really was to identify there's a problem. They would manage the less complex cases, medical evaluations as needed, and they were really the physician of record. The care manager, again, we talked a little bit about what they did. They were the primarily translator of specialty mental health expertise into that general medical setting. They were available to help with that initial assessment and triage with the primary care doc. They did a lot in terms of initial patient and family education, care coordination, follow-up, outreach. They were the glue that made this work in so many ways. They did a lot of treatment support. They would monitor medication adherence and outcomes. They would do safety monitoring, and they did a lot of short-term counseling support, self-management. It wasn't like they were sitting in their office and scheduling people on the 45-minute. they were going from room to room. They were flexible, they were smart, they were practical. My job was really to provide leadership for the team, to supervise and train the care managers. Eventually became the content expert for PCC education, spent a lot of time going to early morning meetings once a month. And then I would do consults for selected cases, and then we would co-manage selected cases. The way the model worked for us is we'd identify the case. That triage and assessment would be done by the care manager with the primary care clinician. And essentially a determination was made whether this was the kind of patient who could be managed in routine care, whether they had to go, do not pass go and go right to specialty mental health care, or whether they might be best managed in the practice by this interdisciplinary team. We didn't start out with this rubric. We were doing this for a while, and it was like, oh yeah, let's write down exactly what we're doing. And this is how it evolved. There was that initial triage. Occasionally you had to send somebody for an emergency assessment. Didn't happen a lot, but it sometimes happened. The patients who went to routine care, they were mild to moderately impaired, relatively low complexity. They had had either no prior treatment experience or they had had treatment in the past and responded. And their treatment needs were relatively straightforward. They needed some psychoeducation, they needed some training in self-management, maybe get activated, get back to school, back to work, that kind of thing, and maybe some straightforward medication management. Those patients who went to specialty care were more severely impaired, much more complex. The big issue was, did they have a family that could help focus and work with the team? If they couldn't, a lot of times we needed more case management that we could do in primary care. This group was of somewhat either intermediate complexity or impairment, different levels of treatment needs. But we were able to oftentimes begin to manage patients here with the goal that we would send them back. And so this is essentially a stepped care sort of model where there was fluidity. People could start here. You were a kid with ADHD and then you didn't respond, or you all of a sudden it's like, gee, they're depressed too. They might be managed here, stabilized, sent back. So it was a fluid sort of model. What I will point out on this slide is the case flow. We really went back and looked at compliance with that initial triage referral to the care manager. And what we found was that about 90% of these cases, when we identified the problem, we said, okay, we're going to connect you with the care manager. 90% of the time, they actually got some services. And so just in a very simplistic way, we thought that was a whole lot better than what we were doing with referral. Now, we took this model and we have done this in research settings as well. So we looked at kids with disruptive behavioral problems and applied a collaborative care model. We ended up randomizing 8 primary care pediatric practices. Half of the practices got a collaborative care model where each practice had an on-site care manager. We had content modules, and we did a lot of things for the primary care docs in that in those practices. The comparison practices was enhanced usual care. All of the kids had a very detailed assessment. The primary care doc got a summary and communication, and the person who did the assessment helped them get specialty referral. What we ended up finding, and again, it's a pretty big study, we did over 300 kids, the kids who were in the collaborative care condition were more likely to get involved in treatment at all, just over 50% in the enhanced usual care group. They got more treatment, more service. They were more likely to use medication if they had significant ADHD. They were more likely to complete a treatment course. Their treatment response was better, and it was maintained even 1 year out. And what we also found is the patients and their families, they preferred this to referral, and providers liked it better. The final study that I'll talk to you about is a study that applied a collaborative care model, like the ones that were talked about earlier with adults, to adolescents who were depressed. This is Laura Richardson's work from the University of Washington. And they did an RCT for adolescents who were depressed. And again, they did a collaborative care intervention and compared it to enhanced usual care. The intervention, they put it out over 12 months. And what did they find? It was a little over 100 patients. They randomized them. Patients in the collaborative group were much more likely to get treatment that met quality standards, much better treatment adherence and completion, much better treatment response, more likely to end up with their depression being remitted, and the patients and families liked it better. So what's the conclusion? What do we know? Well, there's a lot we don't know, but what we do know is that both structural and attitudinal barriers to integration of services and to delivery of behavioral health services are relevant. But I really do want to emphasize the importance of attitudinal barriers. How we think about this is important. And I think if we just address the structural barriers without real cultural change, and that's what the NPA has the opportunity to do, is real cultural change, I don't think we're going to get the outcomes that we otherwise could. What we do know is that people have demonstrated that collaborative care interventions as a means of integrating evidence-based treatments in the medical setting, it's certainly feasible. It's been shown in lots of studies in adults, you saw over 90 studies in adults, that it's going to improve access to behavioral health services. It's going to improve outcomes for at least a core group of common conditions. It's going to be associated with better patient and family satisfaction, and in general, providers are positive about this. So I've already prattled on longer than I should have, so I'm going to stop here. I'm going to put up with just a couple of references, but at this point I can stop and we can see if there are any questions or.
Absolutely. Let's thank Dr. Campo. Yeah, great talk. We have time for a few questions.
There's a link between microbiota and mental health.
I'm sorry?
There's a link between microbiota and microbiosis and mental health.
Do I think there is?
What's a probiotic?
Certainly the research there is going through the roof. Everybody's very interested in the use of probiotics and the microbiome in terms of things like anxiety. I have one of my faculty who's studying this in infants and its impact on psychiatric disorder. I think right now the answer that I would give is there's a lot of smoke around it, but I think there's much we have to learn. Do I think it's worth looking further into it? Yeah.
Because it's linked to insulin resistance and diabetes. So it's linked to insulin resistance and diabetes, microbiosis. Maybe linked to
I think the whole thing, what's the relationship between the gut and our brain, the gut and our behavior, the gut and inflammation? I mean, I think that I think when I think about the nervous system, there's the hardwired nervous system, and then there's the wireless nervous system, which is basically all of our inflammatory cells, and it all connects, and it all talks centrally. So, thank you. Other questions?
Other questions?
How long did the care managers follow these patients for typically in a collaborative care model?
In the real world practice, there were some of those patients, they were followed for a long time. If they had sort of, let's say you had a kid who had really hard to manage attention deficit disorder and a lot of other problems, that care manager might pair up with that primary care doc to really help manage that kid and help be a liaison with the schools. I mean, their job was really, it was a team. It was a team. No, sorry. Does that answer the question? I mean, I think that what you're getting at is that there's only so much care manager to go around. And so these people need to be light on their feet, and there needs to be a lot of give and take between primary care, between the care manager, and then also on the specialty mental health side. You really can't do this if you have a specialty mental health team that isn't willing to take the difficult patients or consult on selected cases. It's a team effort. Everybody plays a role.
And you added social to your team at some point. Is it later on?
Yeah. You know, I think that one of the questions that you'll hear people talk about is what discipline should the care manager be? There are people who have worked this model using bachelor's level people. People have used master level social workers. There are PhD psychologists who have done a fabulous job with this, guys like Kirk Struzel early on. Nurses, advanced practice nurses. I don't know that there's any one discipline. It really depends on the model you work. And I think that if I were to make one suggestion, and the thing that we're trying to do in Ohio right now is how do we conceptualize and train a type of professional that, for all intents and purposes, doesn't quite exist, right? If you take a traditional mental health professional and you plunk them down in primary care, it's easy for them to co-locate. Okay, there's an office, I'll schedule people every 45 minutes, and in 2 weeks I'll have a full schedule and you won't see me anymore. On the other hand, you need to have some appreciation and understanding of mental health conditions. I mean, if anything, to be good at being a care manager, one could argue you may need to be more experienced rather than the specialty mental health clinician, because you have to be light on your feet and you have to be able to move fast. We were talking at lunch, there's a saying from William James that goes something like, wisdom is knowing what to overlook. Takes a while. Other questions?
I think
Thank
that's a
you.
pretty good place to start.